you so much, ma'am. So, in case you look at some of the scattered data which we have in our country, uh, it's not clear, but they say we have around 50,000 gynecologists in India. Some say 70,000. It's a huge number. Even if we say 50 is half a lakh number of gynecologists we have in India, the largest all over the world. Out of these gynecologists, I think around 27,000 are registered with Foxy. That's what data says. Now, one thing is very common amongst all. One thing is very common that all of them are managing fertility cases. In case we get a patient with a cancer, advanced cancer, or a difficult fetal problem, we normally refer the patient to somebody else because we can't do that thing. But ART, which encompasses IUI and IVF, is being dealt by everybody. That's one common thing which every gynecologist is doing, and in the past 4 or 5 years, it becomes so simple that all of us want to somehow convert into IUI and IVF. Today's my talk will be that when and how to shift, how can a gynecologist shift to ART. It's not about doing a procedure, it's about physically and spiritually shifting towards the ART. And ART, as you can see, is normally when we say ART, we say it's IVF, but for majority, it can be also be IUI. There are 4 levels of gynecological practice which are pertaining to ART, which we are doing all over our country, all over the world in fact. You'll find that some people are doing only basic gynecology. They are the people, the gynecologists, as we were 15 years back, we were in peripheral part of the country. We were doing general gynecology, cesarean, hysterectomies, and doing some amount of infertility, learning infertility by reading few books, and then inputs were basically by medical representatives. Now this represents a majority of the gynecologists in the country who doesn't have an access. Now they do have with online teaching, but normally they can go to Google or learn something about what's happening in IVF. Second is the one who really want to shift to ART, that is IVF and IUI, and they have keen interest in ART, and they're in touch with the people who are doing IVF or IUI. They come and do some short courses, Foxy, ICOG, they do a lot of short courses and learn something for overnight, weekend courses or long courses. They have learned that a large number of population having infertility is due to the male factor, so they refer the patient to the ultrasonologist or an urologist or an andrologist. Their basic knowledge comes from conferences and meetings. They go and attend few workshops, spend some money, and they become better day by day. Now, the third category is the referring population. This is not less. Here we have the group of doctors who are doing gynecology, but they want to shift to IVF now. They're doing IVF. They want to shift to IVF. So what they do is, they go and do some short courses somewhere, and then they start doing stimulations and referring patients to ART clinics. So they'll refer to somebody, they will stimulate, take the patient there and do their pickup themselves under observation. So they are dreaming to become independent one day, so one day they will work without observation and work independently. And fourth are the trained ART clinicians like us who are good for nothing, but we only do ART and embryology. So my understanding, looking at the population here, all of you are here today, that you are all very busy practicing gynecologists. You're all doing IUI, and few of you are dreaming to do something in IVF, or you're referring patients after stimulation to an IVF unit. And you would like to know, is the time ripe for me to shift to IVF completely? Is it right? Can I handle it? Do I have it in me? So let's see whether you have it in you. And all of you will be having short background of doing some small courses here and there about IVF. And then you are all working in primary or secondary level ICMR units, and you want to shift to a tertiary level of ART clinic where you can carry out IVF. Now before we move ahead, why all of us are running towards ART? What is there in ART which makes it so simple or so uncomplicated that we feel that okay, we can all do it? Having an advanced malignancy, having a totally frozen pelvis, we normally may not touch. हमसे नहीं होगा, किसी को बुला लेते हैं, कर लेते हैं. But IVF, we feel that okay, everybody can do an IVF. IVF is so simple that everyone can do IVF. Is it that so? The things which I thought so, I think Dr. Sharda has brought a very spiritual aspect of 2040 and life balance. These are the things which I thought maybe in our minds, a midlife crisis. We are at 40, 45, and we have done a lot. We want to do something new, something different we want to do. What to do? At 45, 50 people, probably we cannot go and learn robotic surgeries. We may not be able to learn how to do amniocentesis or CBS. So one thing very simple is that, okay, IVF is one branch which we are handling every day. So let's learn something new and we shift towards IVF. Another thing that we want to shift at around 45, 50 to a more peaceful life. So we want to probably, we may be running away from obstetrics. Just we have to keep our hands on our heart and ask ourselves, are we running from obstetrics? And then we find it's a new branch is coming up. It's very glamorous. It's very, very nice. And so much of technology is there. Probably a lot of easy money. Though challenging, easy money. We have around 25-30% of our population or OPD needs IU or IVF. They are paying population. And then the high failure rate. This one thing, 50% of people will fail. So we sweet talk, we say we have done a good job, but we have failed, 50% have to fail or 60% have to fail. And so this gives us a protective curtain. If we do 10 cases, 3 come positive, we make Allah, we are happy. But we assume that 60% of cases, 6 will definitely fail, so we are having a curtain around us. And then definitely it's quite a glamorous branch as compared to the old existing branches. So we all dream to have a nice OPD unit. We have an OPU unit. We want to go to home pickup, ambulatory transfers and beyond. And we also want to do some sort of research publications, write few papers and get some sort of recognition. We also want to have a nice unit where we are working, where we can do advanced embryology, PGS, PGD, onco-ART, embryology. A lot of things are there which we all are doing and we all want to do them. So we want to move away from obstetrics and gynecology and shift this side. So are we clinicians in a hurry? Are we doctors? Are we in a hurry? So we want to shift to a newer branch at 45, 50 or even earlier. There was a time when the young gynecologists, when they passed out, asked, what do you want to do? They all wanted to do oncology or laparoscopy. They wanted to do more, where they have more of surgical skills. But now, not that we don't have any surgical skills, but people want to have a more comfortable life. So the young doctors who are passing out, what do you want to do? We only want to do either fetal medicine or we'll do ART. So why is it so easy to do? We only need 3 rooms of 150 square feet area. We have these 3 rooms in our clinics. We are done. We put up a board outside our unit that we are XYZ, we are doing newspaper cutting fee, we are circulating pamphlets and we advertise few awards in our clinic and we are on towards doing ART. Then it's very simple. Spend around 10-15 lakh rupees, then hire an embryologist or a clinician from somewhere. So they come to your unit, you make batches, they take some money from you and we are having okay results. We get 3 out of 10 positive. It's so simple actually. We only need 3 rooms of 150 square feet area and we hire embryologists and clinicians. They just come to your unit and do your cases. Or if not so, what we can do is that we can start working up our own cases and take it to some other unit and start operating them, which has got a basic IVF unit, and we advertise, okay, we are also doing IVF and get a lot of referrals from other visiting doctors. And the best part about this is that we can continue with our OBG-Gynae practice simultaneously. Now this is where what Madam just said, 80-40 rule will come as we move ahead. That is not the way to initiate into IVF services. We have to cut the umbilical cord. That is a must. As Madam said, we have to say big no, only then we can go into a serious IVF business. We can't be doing an hysterectomy in the morning and evening we want to do pickups and some amount of embryology. Yes, we can do that, but it won't be a very serious business. So we have to cut our umbilical cord, and that's a 20-80 principle also. Anyone who can walk slowly, gradually in IVF will win. It's not a branch which you just have a lot of things happening, you cut open and we do big surgeries. It's a very quiet and spiritual branch. I always feel the people who can walk very slowly, tread very slowly will win this game. It's not like that. You can't win the race by putting some propellants here. You have to be very gradually initiated into IVF or ART. So conversion to ART now. Conversion is a gradual process. It will take some time. It can't happen overnight or by doing few diploma courses here and there. It's a very gradual thing. It's going to take some time for all of us. We don't have to only control ourselves. When we say that we have to control our own mind, we have to control the whole environment around us, we have to control our team members, and we have to make a good team before we go into IVF practice. Surgery, cesareans, hysterectomies, laparoscopies, fetal medicine, it's a one woman or one man army. When I was doing active gynecology, I never required anybody else. We could operate anywhere. We just required a scalpel and suture material and one assistant. Open up any patient and do anything. But in IVF, howsoever good you are, you can't work till the time you have got the team with you which understands what you are doing. They have to be with you actually. And until that time, I propose that none of us should go into IVF practice. And you should also know what is my end point, where do I want to go, and what do I want to achieve. So we have to introspect about our careers. We have to introspect the concept of cutting the umbilical cord and how serious we are about getting into the practice. So ask yourself, am I a trained ART clinicians? We are all gynecologists, and all gynecologists are trained in IVF also. We read about IVF. So are we a trained ART clinician? Am I optimally self-motivated? Can I take failures? Success, nobody will ask you. But once you get a failure, patient, they just sit on your, they're also right. Any informal training fellowships I have done? Do I have any certifications? Or I just want to shift to IVF by observation, watching some YouTube videos? Do I have any experience or plan to learn on the job? These things you have to ask yourself before we shift to ART. We have to have basic knowledge. Now, what all should be actually doing? We can always go and attend courses and learn, but these are the 4 factors which we have to learn thoroughly in case you want to go into IVF. Factor 1 is a basic and advanced knowledge about sonology. You have to learn what IVF, what ultrasound is all about. We have to learn about endocrinology. What is FSH, LH, the correlations, and what is AMH, inhibin, how do they correlate? We have to learn. Only then you'll be able to interpret the reports properly. Quality control and quality assurance. I'm very sure that in case we manage our lives well, as madam just brought out, and for the women, I always feel that, and the women who manage kitchens at their home, for them managing a laboratory and a clinic is very simple to do because they are trained to take complications every day. So their quality control, quality assurance is very good. This one factor you all have, I'm very sure. And you must have had a good experience, hands-on experience under a good, capable, able teacher. So these basic knowledges are required, and most important is we have to know about laboratory working and drug and media procurement also. Till you don't learn these things, don't go into IVF. IVF anybody can do. Anybody can, it's not a rocket science, but until you won't know about these things, it won't progress. I always feel that doing an IVF is a very simple procedure, but when we have complications, we don't know how to come out of it because you won't even recognize what has gone wrong. So it's like this battle which we had, getting into the Chakravyuh is very easy. But coming out of it when we have problems from ICMR guidelines to our daily working is a pretty complicated thing. So success of all of us is not in getting in and starting an IVF unit. The success would be in surviving, and it's a very grueling path, I must say. Performing, sustaining and taking the team along is a big challenge for any ART clinician. We have to know that our patient is a team member, he is not a shareholder, and he is an equal shareholder. We can't say that we have come negative, we have tried our best, because there is no trying the best. In case we have failed, the success is 0% for him. In case we succeed, it is 100% for him. So they are part of us, and we have to counsel the patient that your chance of failing is more than 50 to 60%. And we all work in tandem, we all work together, and as is rightly said here, that individual talents get magnified multifold in case we work collectively as an effective team. This is what IVF requires, and this is what we don't do in gynecology. Gynecology, we work independently with an ORA or probably with a nurse or a technician, but here a lot of people have to work together and we have to take all of them together too. So testing waters. You want to start something, and there are many ways you can cheat people. The shortcuts are there. Then somebody will tell us, you are cheating, who cares? This is what my next speaker is going to talk to you about, how to avoid complications. There are a lot of recommendations. Some are, these are all bills which are lying in the parliament, so we have to know about them. ICMR guidelines, you must read before you want to shift into ART or even IUI or IVF. There are few of them. You have to know about manpower and infrastructure, what all you require, how much training is required, whom all we have to hire. We have to know about these things. So this is the team which is required to do IUI or IVF. As you can see, a lot of people are required. We also need a legal and a financial advisor. Then we need ancillary staff. And besides everything which is present here, again I'm going to the 20-80 ruling. This is the one which is the most important. In case we have good ancillary staff and legal advisors, we have done 80% of the work. This part anybody can do. Anybody can become a program director. Anybody can become CEO. Anybody can become. But we need good ancillary staff, the people who maybe brooming the floors, who clean the OTs, who mop the floor, to good legal and financial advisor. Sir is there. He's going to talk about legal help which is offering to the ART units. So this is what actually we are looking at. This is what we are. But what is going to give you success is the lower two. Then these are the areas which are required. These can be created. This is basically infrastructure. We have to spend some money and create these areas, but these are required as per the law. Then there are two working models which are work broadly. One model is that we have one OTN lab which is being which is a hub, and we have multiple spokes where any clinician can go, any embryologist can go and work there. So it is not theirs, but they are working there. And the second, but this model is not the right model. The right model will be that we have a standalone center with multiple house clinicians and embryologists. That's the way China works. In one center, they will do in a month, they will do 4,000 cases, 5,000 cases. They have a very robust lab and OT. But in our country, majority of the people, we are working on spoke and hub model, where we have one hub and multiple clinicians and embryologists go there and do their cases. So that way we really can't succeed. So we must have a standalone center. The parameters for success, do we have it in you? Do we have it in us? That's what I should be writing here. That it's a very different ball game here. We just can't say that what I'm seeing here is pigeon's eye. That's okay when we are a gynecologist. We see pigeon's eye and you are Arjun. It doesn't happen here like this. Here when we're doing an IVF, you have to look at the tree, you have to look at the hut, you have to look at the river, you have to look at the grass, you have to look at the sky, because you're going to manage, you're the program director. As a gynecologist, you'll all be program directors. You can't say, "Meko to pata nahi hai." But here, you're not only managing the patients, we are managing the atmosphere, environment, you are managing the asepsis environment, you are managing the people who come to, you may be a very good doctor, but your embryologist will come to the laboratory wearing some nice nail paint. Or she may be using some good soap which has got a fragrance, and we have lost everything. So we have to keep a watch what people are eating. Is my embryologist or a technician smoking? Somebody may come to clean your floor and he has smoked a cigarette or a chewing pan and is cleaning the floor. We have lost it. So you have to keep a complete watch on the environment. So I always feel, and though they apply to all the gynecologists, to nearly everyone, but here specifically eagle's eyes, observe everything around you. Observe but don't speak. Once you speak, you lose people. You have to just correct them very, very gently. That's the most difficult part, because the talent here is very rare. We don't have many trained people. So even if they do something wrong, if we just very gradually coax them and put them on the right track, have ladies' fingers, very soft touch, lion's heart, and foremost of all, again, 20-80 rule, 20% which becomes 80%, very gentle soul and heart which beats for the patient. Until we won't have this, we can't succeed. Sensitivity, passion, team working is a key word when we carry out IVF or IUI. Crying with the patient in their success and failures, I think we should all have it. In case we don't have it in us, we feel, okay, 50% has to fail, she has failed. Then I think IVF is not meant for us. Until we won't shed tears for our people who are crying. I think we have got no right to be in IVF. Letting go of the glamour and cosmetic facelift is again, we have to actually let it go. Maturity to accept failures and moving ahead is important. Helping everyone to grow is very important. We can't say, I have done 100 hysterectomies. No, you have to make people working with you, you have to help them to grow. That's very important. And in case you all work together, I think we can lift bigger weights. The art of getting into the ART, why, when, how is the question. Now we have decided that, okay, I have it in me, I have to do IVF. I want to go into ART, how to go? Why, when, how? So we'll have an entry portal of either a clinician or an embryologist or a technician, depending upon how we want to enter at our level. Very few centers in our clinic in our country are registered. So we must get a center accredited. Now this is the actually horoscope of our country's IVF scenario. This you must know that in our country we have nearly 8,000 units which perform IUI. 8,000 units, but they may not be registered. We have around 1780 IVF centers, and we are doing around 2.5 lakh cycles per year. That includes all FETs and whatever we do. Total 2.5 lakh cycles we are doing per year in 1780 centers. These figures you keep in your mind, and now I'll move ahead. Total practicing embryologists in our country are nearly 1,000 to 1,200 who are qualified, and they are doing 2.5 lakh cycles. Qualified embryologist nearly 1,000 और वो लोग 2.5 लाख cycle कर रहे हैं हमारे देश में. ART trained clinician, that applies to all of us now. We barely have 1,500 trained clinicians in ART. 1,500 trained people in our, even I do IVF from 15-18 years, but I don't have any training from anyone that I've trained. We have learned on the job. So trained people are barely 1,500. Barely few centers are registered, as I just told you. Fellows are around 500. Out of this 1,500, 500 fellows हैं जो भी पास हुए हैं 2 या 3 साल के अंदर. They don't have much of experience. And so you can calculate the visiting clinician center ratio. We know that 2.5 lakh cycles and only 1,500 clinicians. How do we maintain that ratio? Now this means that probably an embryologist is going to multiple IVF clinics, going to 5 to 7, 5 to 10. I know embryologists are visiting around 10 IVF units in a month. So there we can't have success because we have so many people doing this. And same thing with the clinicians. They are catering to 2 to 3 or 5 different. They are traveling and they are doing pickups in various parts of the country. So what is important here is, what we have to understand here is that we got a very, very good chance of coming into ART. There's a demand, there's a severe deficiency, and growth rate is around 18% CAGR. That is the annual growth rate in IVF cycles in our country. From 2.5 lakhs, we'll be touching minimum 5 lakhs by 2025. 2.5 lakh से 5 से 6 लाख cases बढ़ जाएंगे 3 साल के अंदर 4 साल के अंदर. So there's enough place for anyone who's interested. That's the best part out of it. So IVF, which when we are shifting, we feel that IVF is a very glamorous and glorious branch. Okay, we sit in the Orient Express and we are being served nice red wine and good food and croissants and cake and cheese. That's the way we look at IVF. But when you go to IVF, जब patient आके आपसे लड़ेंगे, झगड़ा करेंगे, you realize in 15 days कहाँ फंस गए. So IVF is like this. It's a very, very grueling and stressful job. Don't get into it completely till the time you have not decided. There are no shortcuts in IVF. Because you'll fail or pass. A cesarean, when we used to do cesareans, the quality of the cesarean, how we did, was quantified by कितना जल्दी patient को पानी पिला दिया, कितना जल्दी patient has gone home. Scar कैसा है? अच्छा scar अच्छा बना है. Scar is not seen. It's a bikini scar. He's a good surgeon. अगर स्कार बड़ा भी हो गया, 4 इंच का हो गया, 3 इंच का हो गया, तो that made someone better doctor than the other doctor. But the surgery has been done, बच्चा तो मिल गया, or uterus is out. But in IVF, it is not. We have tried, we have done. It is either you have got a baby, beta hCG is positive or negative. That's the point. So here you either pass or fail. There is no question of we have tried very hard for you. You have passed or failed. So there are no shortcuts. When you go into it, people will tell you do this, pick up some eggs from there, pick up few sperms from there, embryos de do. No shortcuts here. The basic philosophy of ART is what We want to do what we can do. That doesn't work like that. For IVF, things you should do are you have to pick up the best thing from both the sides and start working in the middle somewhere. So it's a very spiritual aspect of science. It is not a technology only where we play with somebody's body using some instruments. It is a spiritual science. A bunch of unfortunate people are fighting a curse of God. In case you won't understand this, we shouldn't go into ART. Then we should be happy doing our regular practice. We are treating the extended families. Bhaiya, Bhabhi, the grandparents and in-laws, everybody is watching that girl who's coming to you from far away. Kiska bacha hota hai ki nahi hota. They don't have money, so they are borrowing money from everyone. They get 2 lakhs to you. We've done a case. Everybody is watching. And your 60-70% of cases will fail and then in the talk of the town. So we are treating an extended family. We're not treating a couple who's come from corporate and got their cesarean done. It is IVF. So it's more of a socio-psychological process which we have to understand. They ask, why do ART clinicians who are actually very good? I ask everyone, the top people, honchos, I ask, आप IVF क्यों करते हैं? Now probably they would have become commercial, but once they started, it is one very common thing that we are creating a society. We are not creating babies. Babies can be done by anybody. It's a carpentry. We are creating a child. We are not only creating a child, we are creating a society, avoiding divorces and propagating women empowerment. That is the goal we should be having, that we have to help women grow, help women take off the label of being infertile and being bunch, and driving in Mercedes and getting a lot of money, glamour quotient won't take us far in ART. So ART is lifting a lot of burden. It's not fashionable, as are deodorants and alcohol and smoking, or using some hair colors or nail paints or lip gloss. We can't use them in IVF. We can't even wear rings. We have our soaps, the type of soap which we use is to be quantified. We can't use any soap. I mean, I don't remember last time when we used any perfumed soap. So we have to make a choice before getting into it. So how do we get into it? Do some fellowships. These we all know that a lot of people are doing multiple fellowships. We'll find a lot of BComs and BAs in our country, they are doing embryology. So we have to decide what is our qualification, how to move forward. These things you all know. So we have to know about infrastructure, finances, training of the teams, hiring of the teams, and foremost of all, conquering mind. This will again become 80%. So to conquer our mind, this all will be very, very simple. So this is a design. It needs a design. It's a standalone building. We can't do IVF in our OT where we are working. It has to be a separate OT we have to create. It's not the space which we have. All that space you can easily create, but the space has to be separate from your main working atmosphere. This you have to know. And then you require around 2,000 square feet of area to create an ART unit. And these are the things which we have to keep in mind. Manifold, UPS, plumbing, air handling unit. These are the things which will lead to your failure or success. So focus on these things also. Equipments will cost around 60-70 lakh rupees, maybe cheaper depending on what you buy. So the amount of investment will barely touch around 1 CR, including your OT and lab. And that is actually not much. So finances can be built up, we can take loans and we can break even soon, that's also there. And the total expenditure, if you want to start with an IVF, in case we have a building already, is around 1.5 CR. Max, you can make a tertiary level ART unit with this. So the most important criteria which are there to become an ART clinician, again 2080 law, your mind, sustainability and respecting law. In case we have these 3 things, you will be able to sustain, otherwise you will start, it will shut down. So these 3 factors you have to actually understand and take it forward. You have to fight a lot of battles. You will have a lot of enemies around you. And here I say, go to SWOT analysis. I'm just finishing my talk here. This is, we have to know our strengths, weaknesses, threats and opportunity. Then we have to understand where we are and how do we convert our weaknesses into strength. One big factor we have, all of us we have, the doctors we are actually good. We have a lot of motivation, dreams, teamwork and finances, and opportunities always there. They told you it's a new field. 5 लाख केस होने वाले हैं, डॉक्टर हैं 1500. So anybody can join the bandwagon, no problem at all. Rapid growth, quick money, relatively lack of competition for good doctors. So we can all become ART clinicians. Glamour, yes, glamour is also there. But here we have weaknesses and we have threats. So you have to know where am I lacking and then convert these two things into our strengths. So take home message is we have to act responsibly. That's very important. And somebody is always watching you. Somebody is always seeing what you're doing. So be careful before you go into anything else. And more than that, we have to have our own moral policing. We have to do our own policing. You watch over yourself. That's very, very important. And it's a social responsibility which we are doing besides doing scientific treatment. We have to share our knowledge, which your forum always does. I mean, really appreciate that. And we, if possible, have a spiritual peace of mind. And be humble when you succeed. It shouldn't go to your head. You will do 10 cases today, you will get all 10 positive, and next time for next 5 OTs, all will be negative. We don't know what's going to happen to you. So be humble when you succeed. That is very, very important. And when you get down, you fail, you have failures. Always, it's not about money which you have made. If somebody has told you, you will be kicked. We'll all be kicked. We get kicked every day by the patients who fail or by ourselves when we make mistakes. So we fall down every day, and the winner is the one who will succeed, is the one who will just get up and do it properly again. Thank you so much for the patient.